I understand some of you may be new to PSC, some of you have been around PSC for a long time, so hopefully this will be an opportunity to learn more about PSC, what are the issues, can I close this? And give you an opportunity to ask questions. So there's a little program we've got going, but obviously these, typically when we have these, some of you have been doing them before, it's really an opportunity just to get your questions answered. So anyway, with that, I'm just going to start with a brief introduction to PSC. Some of you may have seen this before. We had our meeting in Sacramento for PSC Partners about a year ago. So briefly, these are some of the main questions I think everyone with PSC has, and that is, what is it? A lot of you know what it is, as well as physicians. How will PSC affect me? And a lot of times it's very helpful for you to discuss this amongst yourselves. I was just talking to a patient over the phone yesterday who'd been diagnosed a few years ago, and she was pretty much asymptomatic, and then over the last 6 months or so has developed just horrible right upper quadrant pain. And she's gone through all sorts of testing, can't find out what it is other than the PSC. So there's all the ways that it affects you, aside from the horrible things and in terms of progression of disease, just the other quality of life issues that people deal with. What can you do about your PSC? And I think that's a big question, because right now we don't have a proven therapy, but there's a lot of research being done on that. Why did I get PSC, and will there ever be a cure for PSC? So first of all, what is PSC? Well, primary sclerosing cholangitis. If you break it down, primary means that it's not secondary to another cause. In other words, we don't know why it happens. It's a primary disorder, although most people have inflammatory bowel disease, so we could say it is secondary to inflammatory bowel disease. But other people get sclerosing cholangitis from infectious causes, from problems, from diseases, rather medications, I should say, or stone disease, gallstone disease. So there are secondary causes of it, but in the case of PSC, there is no known underlying cause. Sclerosing just means that there's scarring or stiffening of the connective tissue, and that's what happens to the bile ducts. And then cholangitis simply just means inflammation of the bile duct. So that's what the basic primary sclerosing cholangitis refers to. And if we look at what PSC looks like under a liver biopsy, one of the real hallmark features are these thick bands of fibrous tissue or scarring that encase the bile ducts. And that's what essentially is squeezing them off. There's loss of the vasculature to the bile ducts, and eventually that bile duct will go away, and all you're left with is a scar there. It's a little different than what we see in other types of liver disease, where the scarring is not so circular or concentric. It extends more outward into the liver itself. So that's one of the unique features of PSC. And what this leads to when we look at what we call a cholangiogram, or an image of the bile ducts, is that instead of having a nice tree-like structure here where we have a main trunk and branches off of it, we see a ratty sort of looking biliary system or bile ducts with areas where there's strictures or no bile duct, and then behind it a very fat area because the bile can't get through and it gets dilated. And you can even get these little sacculations, which are just big collections of a big bile duct that's sort of ballooned out due to the fact that bile cannot get out of the biliary system because of those strictures. And this is typically what we use to make the diagnosis, not usually a liver biopsy, at least in the adults. I think pediatrics, you guys do more liver biopsies than we do. So there are differences here between the pediatric and adult PSC in terms of how they present and how we manage them. So 3 main things about PSC. Unlike most diseases where we think they're sort of an autoimmune phenomenon, in PSC, men are more affected than women, about 3 men to every 2 women. Most PSC patients we talked about have inflammatory bowel disease, and if you have been diagnosed with PSC and you haven't had a colonoscopy, you need to have one, because oftentimes that inflammatory bowel disease is completely asymptomatic. In fact, I've had patients that actually complain of constipation and then you do your colonoscopy and you find some inflammation. And then there's this variant called small duct PSC where that cholangiogram looks normal, but the liver biopsy is consistent with PSC. And that's a small group. It only makes up about 10% or so of all the PSC patients. And they have a little bit different prognosis. It's a little bit less aggressive disease, but can over time turn into large duct PSC. So how will PSC affect an individual? Well, it's unpredictable, really. It varies from individual to individual. It also varies over time. You'll often see that there are flares where someone looks very sick, and I think I've seen this mainly in the younger patients where they get, look like things are really going downhill fast, and then it stops, and then it's just a more slow, steady progression. You can also have what we call dominant strictures, which is one major stricture that causes obstruction of bile flow, and once that's dilated, then things can look better, although the disease again can progress over time. On average, the time from diagnosis to liver transplant is 12 to 15 years, but that's average and quite variable. Some individuals may never need a transplant, may progress very slowly. The two main ways in which PSC can affect people is through the bile duct obstruction. We talked about the jaundice. Also infection, something called ascending cholangitis. So if bile does not get out of the liver, it is a source of infection, and that presents with pain up in the right upper side, fever, and jaundice. And so some people need to be on antibiotics. Sometimes they need ERCPs to treat that. But that's one way in which people with PSC are affected, but that's probably a minority of patients with PSC. And then with the disease, just like with any chronic liver disease, it can ultimately lead to cirrhosis or end-stage liver disease. And that's where most of the time we're talking about liver transplantation, once you get to that stage and develop complications of the PSC. There's also the concern about cancer in PSC, but it's important to recognize that most people with PSC do not get cancer. There's an increased risk, and we have to be aware of that, but it's not an absolute certainty by any means. And there are two cancers in particular to be concerned about. Bile duct cancer, or cholangiocarcinoma, is relatively uncommon actually in PSC. I mean, if you look at the total number of people that have PSC. In terms of what to do to try to diagnose it early so it can be treated, there's not a lot of evidence, but I think most of us recommend checking tumor markers for it, at least annually, kind of every 6 months, in some sort of imaging study. I know the Mayo likes to do ultrasounds. I tend to do more MRI, MRCs, at least annually, or annually I should say, I get them. But either of those should probably be done at least annually. There's also an increased risk of colon cancer if you have inflammatory bowel disease. So if you have inflammatory bowel disease, there's already an increased risk of colon cancer, and then on top of that with PSC it goes up even higher. So if you have inflammatory bowel disease and PSC, you should be getting your colonoscopy annually or every 2 years from the time of diagnosis. That's a little earlier than typical inflammatory bowel disease.
Can I ask a question?
Yeah, absolutely.
Do you see more of an aggression with IBD and PSC of surgeons wanting to remove the colon to prevent cancer?
So being more
being more proactive on the
no, I think it's there may be a little bit lower threshold for doing a colectomy, but if someone's otherwise has well-controlled inflammatory bowel disease, and maybe for me you can talk about this since you're more the IBD person, but obviously if there's any dysplasia, that is precancerous lesions, there's either way there's a real push to do the colectomy, and but if someone's got well-controlled inflammatory bowel disease and PSC, I don't think anyone would push for a colectomy.
I agree with what you
There's some controversy in terms of the course of post-transplant patients who have had a colectomy or not. There's some centers have reported that the outcomes after transplant with a colectomy are better, but that's not universally seen, and so I don't think anyone's doing colectomies just to try to prevent that. And now so those were the things in terms of hard, kind of what we would call clinical outcomes, but then there's also the quality of life issues that everyone's dealing with this disease. Mainly the abdominal pain, fatigue that can be pretty debilitating. Actually, I just prescribed something called Provigil for the first time in clinic this past week. Someone wanted to try it. It's been looked at in primary biliary cirrhosis with sort of mixed results there. And it does have some side effects, but she was particularly fatigued and wanted to give it a try, so we'll see how that goes. Itching is another common issue, and I don't know why I'm telling you all this, you all know what's bothering you, I don't have to tell you that. Just so everyone knows that, yeah, I think that's also important, is, that you understand that these are the symptoms that everyone else is dealing with. And, itching is another common problem, and both that and fatigue are things that we have very difficult times managing in terms of trying to give some relief to the symptoms. With itching, there's a whole series of medications and things that we can try. They work in some people, not in others. I've had patients use acupuncture with good success, actually, and another patient swears by lemon juice. So whatever works for that symptom. But if it's new itching, if it's worsening itching, then that oftentimes is a sign that there's more obstruction of bile flow, and so it should be investigated if it's a new or worsening symptom. And then there's always the stress of the unknown. What's going to happen with my disease over the course of time, which leads to important issues about coping skills. What can you do about your PSC? Well, we can talk maybe at some point about URSO. What's the data for URSO? Does it work? Does it not? Is it worth taking? Of course, if you have a large obstruction, ERCP, some people are more aggressive with ERCP. I know up at UC San Francisco, they do, their endoscopist there is very aggressive with ERCP and almost does it routinely with brushings and to look for early cancers. There's a varied opinion on how effective it is just in the routine management of PSC. Liver transplantation, of course, if someone gets to that end-stage disease. Always questions about diet, nutrition, and of course, as we talked about, coping skills. So moving on, why does anyone get PSC? And there's really no good answer to this, but sort of the general scheme is this is a result of both genetic predispositions. We know there are specific genes involved in PSC. There's been a lot of progress in that area, actually. And then there's also environmental factors and things like smoking. Smoking actually protects against PSC. There's this balance of factors that protect us against PSC or increase our risk of PSC, and in a very small number of people, that's why it's so uncommon, those risk factors for PSC outweigh those against it. So if you're a smoker, if you're a woman, if you're Asian, those are all protective against having PSC. If you have inflammatory bowel disease, if you're a man, if you're Caucasian or actually African American, then you have increased risk of PSC. And there may be some infectious causes as well, though that's not well worked out, what might be playing a role here. So when all those things get together in a rare individual, it leads to PSC. Will there ever be a cure for PSC? And the national organizations, PSC Partners Seeking a Cure, and I try to temper them a little bit because there are very few things in medicine we actually cure. And I think we should all be very happy if we have a treatment. If something can change the natural history of this disease, even if it doesn't cure it, slows the progression, alters where the progression of the disease would be what we're looking for. And there are lots of really, I think, exciting things on the horizon. There are many pharmaceutical companies, small pharmaceutical companies, biotech companies interested in PSC. they see PSC as an opportunity. I mean, they're in business, and they see this is a disease that does not have an effective treatment. One of the issues in terms of a lot of these companies getting into studying PSC is our inability to have a good way of determining whether something's working or not. And actually, this is something I think maybe you can talk about with the vancomycin studies. How do we know something's effective or not without watching people over 5 to 10 years? Because this is a disease that's relatively slowly progressive. And what the studies in URSO showed us, the last study, was that even though the liver tests get better, that doesn't mean that the disease gets better. And that's really, that hurts, because we need something to help tell us whether people are getting better or not, and hopefully in a non-invasive way. But anyway, some of the things that are being looked at in antibiotics, including vancomycin, some of these others, probiotics, actually I think the thalidomide study stopped, budesonide, which is like prednisone. And then there's some other newer drugs. This INT-747 is being studied in primary biliary cirrhosis, might be of interest in PSC. There are lots of new IBD drugs that potentially could be of interest. And then the question is, will there ever be a PSC-specific drug? Maybe, but most likely something's going to be used in some other setting and then transferred or found to be effective in PSC, given that it's so costly to find a specific drug for PSC and it's such a small, uncommon disease. So finally, just will there ever be a cure for PSC? This is sort of where we're at. The two researchers. The research proves tall rats are more confident than short rats. At least I think it does. I've never been good at this. What we don't have, though, is actually an animal model that faithfully represents PSC. So that is also a stumbling block for us. And then we also need people to participate in research. And I know a lot of you already are involved in research, and there's several opportunities for research. One of the big efforts over the last 5 to 10 years has been trying to determine what are the underlying genetic causes of PSC. When I first started working in this, we were doing studies with about 300 patients, 300 samples from patients in Scandinavia. This recently, with an international consortium, we just finished up, we've got over 4,000 samples, mainly from Europe. In the US, between ourselves and mainly in Mayo, we probably have about 700. So some of you I know contributed to our collection, Mayo's collection, and there are several other centers that are contributing to all these. So contributing, participating in these studies is quite helpful. And again, we're always looking for individuals that want to either join our registry, give us some blood for various studies. It's really quite helpful, and that's the only way we're going to, I think, understand this disease better and come up with some treatments, and as well as in these clinical trials that, including vancomycin and others that either ongoing or will be coming in the future. It does take participation for us to move the field forward. So I think, just to summarize it, the future actually, at this point, looks really pretty bright for PSC. Excuse me. As I mentioned, 2005 or so is when I first really started getting into PSC, and there wasn't a very organized group of patients in terms of getting funding going. There weren't many, we didn't know much about the disease, and there really were, I think, other than URSO, no real new treatments on the horizon. And now, just 7, 8 years later, we know a lot more about the disease. We understand at least more about the genetics of the underlying disease. There's a very large number of investigators that are coming together to study this disease. There are more therapies on the horizon. So I think we're seeing a lot of progress here. And so hopefully over the next 5 years or so, we'll actually see realization of some of these things being applied to patients. That's sort of the introduction to PSC. I wanted to just, before finishing up here, introduce Liz Mathis, Elizabeth Mathis. She's my research coordinator, works with me. Many of you know her. I'm just going to ask her to pass her card out to you. If anyone is interested in enrolling in our patient registry, feel free to contact her. She can get in touch with you. Essentially what it would involve is collecting medical records in terms of your diagnosis and following up kind of how you're doing over time, and hopefully collecting some blood from you at some time in the future for genetic studies. Okay. So I don't know if you want to take questions now, or you want to, yeah.
What are you finding from the genetic studies? Because you have a pretty good sample size.
Yeah, so, well, it's, so the initial study showed that, excuse me, there is the strongest, excuse me, the strongest association is with a region called the HLA, human leukocyte antigen. And this is a very large region, and it's associated with many autoimmune diseases. And it's incredibly strong in PSC. And there's specific types of HLA that it's associated with. But what the exact gene is that's causing that is not clear. And that's one of the hard nuts to crack. That association has been known for 30 years, 40 years almost. And no one's gotten really any further, even with these large studies. The other genes that have been found, many of them, I should say most of them, are also associated with inflammatory bowel disease, either Crohn's disease or ulcerative colitis, or they're shared with other autoimmune diseases. So, excuse me, this last study that was done was something called the immunochip. And this was a study that was done with multiple diseases of autoimmunity. And they developed a specific gene test to look at all the genes that have been associated with any type of autoimmune disease. And the idea here is to essentially be able to see how these different genes interact or affect different diseases. So we can see in PSC that these genes are associated with it, and then PBC it's this set of genes, and inflammatory bowel it's this, and rheumatoid arthritis is this, and there's this overlapping network. And so rather than trying to figure out, well, what does this gene do in PSC, we might be able to borrow from what's known about that gene in other diseases. So right now there's not a specific, true PSC specific gene or genes, other than maybe one or two. The HLA and the other one has to do with B cells seem to be the two ones, so inflammatory types. So bottom line is that the genes tend to either regulate inflammation, or some of them also are involved in bile formation and transport. And so it may be that you have inflammation, but there may also be abnormalities in the way the bile duct cells function. So that's where we're at right now.
Thank you.
Yeah.
Is there anything coming out of promising out of Norway?
Yeah, so most of this genetic study, so there's an interesting story about Norway. There's an interesting history about some of this. Norway's for a long time been sort of the center of PSC. Number one, because relative to a small population there, they have a high prevalence of PSC. In fact, it's the #1 indication for liver transplantation in Norway. They only do 40 or 50 transplants a year, but that's the #1 indication. And they're very strong in genetics, both in PSC and other fields, so that they've been sort of pioneering that for a while. And as luck would have it, probably 5 years ago or so, a very wealthy Norwegian, totally like the second wealthiest Norwegian, donated a very large amount of money. Was it 10 million or something? Anyway, they're studying on 20?
20.
Well,
20, yeah.
But yeah, it was 50% was matched by the government. But anyway, they've got this pile of money they're sitting on, and I think they have to use it within 10 years or something. And they've been very, very gracious in terms of really promoting others to collaborate with them. So they've been supporting collection of samples and all sorts of other studies, the immunochip that we talked about. The reason why we have 4,000 or 5,000 samples now is because they've been driving that. So most of the focus in Norway has been on genetics, although now that we have some genes, they're starting to try to turn that into more sort of what we call functional studies to try to better understand what's going on.